Well, talk about a hard act to follow. David is very self-effacing, but among the most creative, lateral thinking researchers in this area of how do we care for the most vulnerable, certainly in this country and really internationally, and I've been an admirer of your work for many years, and I'm really impressed by your data and can't wait to see the publication so I can start incorporating it in my talks. So what I'm going to do differently than what David did is pull the lens back beyond cancer to really be talking more about what is arguably a much larger population of older adults with functional impairment, frailty, many of whom have some cognitive impairment, enormous family caregiver burden, and a duration of need for palliative care services that is way longer than the patient you saw in David's slide. And what will be really the challenge to your model is will it still save money for people who need it for 4 years? People who are not predictably dying, and possibly people with less intense needs because they don't have cancer. So that'll be the next step, is to apply models that work in distinct patient populations and distinct settings and seeing if we can implement them and bring them to scale in a much more diverse patient population. So what I want to talk about are some of the data on the outcomes of palliative care as focused on this frail, older, functionally impaired patient population, and then talk about models like the one David presented to you and how we go about scaling them. I just want to begin with what I'm sure you are all very well aware of and caution you about how we interpret data like these. These data show that the sickest and most vulnerable patients cost the most. How are those data typically interpreted by the lay press? That we are wasting money on the dying, right? We are blowing the entire society's budget on people who can't get better and aren't going to get better. Think about what that means. We're saying that the most sick don't deserve care because they might go ahead and die. We really need to challenge that cognitive frame. Okay. Of course, the most sick are the most expensive. That's why we have health insurance. That's why we have health systems, to take care of the most sick. So to even begin to contemplate the notion that somehow care spent on people who then go on to die is waste, in my view, is completely immoral and unacceptable, and we need to not accept it. I would then say how we are spending money on people who ultimately go on to die is subject to challenge. But not that these people need care. Of course they do. You and I don't need care because we're not sick. That's why we're cheaper. Okay. So these are Medicare fee-for-service data. On the left-hand side, you see that 90% of Medicare fee-for-service beneficiaries account for about a third of all Medicare spending, at about $8,500 per Medicare beneficiary per year. But the 10% of Medicare beneficiaries who have, in this analysis, 5 or more chronic conditions, and this does not include functional status, by the way, account for roughly 2/3 of Medicare spending. And look at the differential in per year spending. So nearly $50,000 in the 10% versus $8,500 in the 90%. So if you were a health policymaker looking at improving value, what patient population would you focus on? The 90%? No, the 10%. So as David said, we finally have leverage because it's our patient population that has the poor quality and the high cost. It's our patient population that is suddenly of great interest at federal, state levels, and in health system leadership, even though they are outliers in terms of their numbers. They are not the majority of patients that we serve. They account for the majority of spending, but they are not the largest numbers. So I took from David a different patient with a very similar experience. This is an actual patient of ours. We met Mr. B in the ED. They live on 92nd and York on the Upper East Side, which is a old German immigrant neighborhood. She makes all her own clothes, and she always makes a tie to match. When I asked her for a photo, this is the one her daughter from California sent me. So he came into our ED, dementia, admitted via our emergency department through an ambulance for management of back pain due to severe spinal stenosis from arthritis. Not cancer, not something he's going to die of anytime soon, but it sure is making him miserable. And he also was admitted to the hospital 4 times in the prior 6 months. Twice for pain, once for falls, couldn't get him up, and once for delirium or confusion because he hadn't had a bowel movement in 7 days. Okay. So very similar to the patient that David described, turning to the ED because there was no alternative, because there was no safety net in the community, and arguably at even greater risk than your 55-year-old patient was from being hospitalized. His primary caregiver is his wife. Their only daughter lives in California. They have a doorman who is around the building during daytime hours but goes home at night, so there's no doorman after hours, and she was pretty much on her own. He knew enough to know that she was calling an ambulance and was pleading with her not to take him back. He hated being in the hospital, just as David's patient did. Mrs. B told us she called the doctor. It was 7 p.m. on a Thursday night. Of course, the palliative care team was still working when they showed up in the ED. She called the doctor, and the tape said, if this is a medical emergency, call 911. It was the only thing I could do. And this story is pretty much universal in the ED. You know, ask somebody, why did you call 911? They'll say, well, I tried this and that and the other thing, and this was the only thing I could do. And as David said, that's the most important sentence on this slide. It was the only thing the system had in place for them to do. We tend to blame the patients and families for misusing the ED or using the ED for primary care. It's not their fault. It's our fault. It's a system design problem. So where is the concentration of risk? And I'll show you some data that supports this. It's people who are functionally impaired. That is among the most accurate predictors of utilization is functional impairment. People with cognitive impairment have much higher healthcare utilization than people who don't. People with frailty, fatigue, unintended weight loss, decreasing ability to walk a block, and or 1 or more serious illnesses. Now, my patient, Mr. B, you could say that his cognitive impairment was a serious illness, but really what's driving the utilization is the low back pain. Is that a serious illness? I don't know. But it is really adversely affecting his quality of life and hers. So just to show you that I'm not making this up, these are data from Judy Fetter and others published by Avalier Health. And on the right-hand side are the top 5% of Medicare spenders. And then they are divided by number of chronic conditions with or without functional impairment. And among the top 5% of Medicare spenders, 2/3 have functional limitations. Okay. So we all know people who on the list of ICD-9 codes have 5 or more chronic conditions but ride their bike every day. Okay, so they may have mild diabetes and low back pain and a history of a past MI and hypertension. But they're healthy. They're functionally intact. It's not the list, the number of ICD-9 codes that determines need, even though we tend to use that because that's the data we have. It's conditions as opposed to diagnoses. So what happens to us? I mean, I think everybody here knows that you can't get off the planet in the United States pretty much without going through an emergency room one or more times, and hospitalization, and increasingly ICU as well. Alex Smith published these data a few years ago. Half of older people, greater than 65, visit an emergency department in their last month of life. Think about it. We know who these people are. How could it possibly be that their safety net is go to the ED? But that's what it is. So when they go to the ED, what happens? They get admitted because something's wrong. And we got to triage them out of the ED really quickly. And thinking about starting someone who's opioid naive on opioids and getting the home care arranged, that's not in the ED mindset for the most part. It's get them out. Quickest way to get them out is send them upstairs. Now, really interestingly, what are the reason for most of these ED visits? It's almost always a symptom. In fact, 9 out of 10 ED visits are precipitated by a symptom. Now, this is not to say that some of these ED visits shouldn't be ED visits, like crushing substernal chest pain in an MI. That's a symptom, but these people should be in the ED. Or, shortness of breath from a PE. But important to note that for many of these ED visits, these are chronic symptoms, like David's patient, like my patient, that really should and could be managed effectively in the community. And as Joan Tino and others have shown, not only is everybody cycling through the ED, not only are they showing up to the ED for things that require good palliative care, but we are increasingly sending people with dementia and extreme old age not only to the ED, not only to the hospital, but to the ICU, including people with dementia. So this is not the fault of patients and families demanding things. This is the only alternative we give them. It's the glide path that we put them on. So we talked about functional impairment. We talked about symptom burden as drivers of utilization. Let's talk about cognitive impairment. These are data from Chris Callahan at the University of Indiana. In his group, he did a prospective study of a cohort of community-dwelling older adults and compared their utilization based on whether they had a diagnosis of dementia or they did not. And look at the difference in utilization. 4 times as much subacute rehab, 20 times more nursing home placement, 50% more hospitalization, twice as much home health, certified home health agency usage, and 3 times as many burdensome transitions. Why do you think that is? Why do you think dementia patients are such heavy utilizers of the healthcare system? They're not calling 911. Why are the families calling? They're home alone, no support. We tend to blame them when they show up with their demented loved one in the ED as abandoning or dumping, but actually we're the ones abandoning and dumping. These are data on how much money we spend on dementia in this country, and this does include total spend. This is out-of-pocket spending. This is days lost from work. This is taxpayer dollars. It's everything in this estimate. $215 billion per year in 2010 dollars. How do you think this compares to heart disease and cancer spending? This is more than heart disease and cancer combined. Okay, so what do you see in the newspapers and the journals? It's all about the high cost of cancer care. The high cost of cancer care doesn't hold a candle to the high cost of dementia care. The 2040 estimates will be about $500 billion. That's my generation. You guys will be taking care of me, all you young people here. With advanced dementia, we're talking about big money here. And this is based on utilization projections from the current state of utilization. So we have to markedly change the glide path, the standard of what happens to this patient population, or we will be paying for nothing else in our society. Not roads, not schools, not public health, not safe drugs, nothing else. Just the care of people with end-stage dementia. So in case I haven't already made you nervous, there's projected to be a 10-fold growth in dementia-related hospitalizations as the numbers of baby boomers get there and a threefold growth in need for community-based support. So hopefully I've convinced you that this is the group we should be focusing on. Those with functional limitation, frailty, cognitive impairment, and or one or more serious illnesses. So this is an overlapping Venn diagram that my colleague Sean Morrison made a couple years ago to basically show that what we need to do is stop thinking about geriatrics and palliative care as separate. The overwhelming majority of patients who need palliative care are old. Most old people don't need either geriatrics or palliative care. They're healthy older adults. They need someone who knows how to manage systolic hypertension, encourage people to eat right, to exercise, to plan for the future. They don't need specialty care in geriatrics and palliative medicine. They need a good doctor, nurse practitioner. But for the group that's frail, that's vulnerable, and you can see the criteria here, they are overwhelmingly elderly. Not all. You know, we've got kids with serious illness. We have 55-year-olds with serious illness. But if you just look at it from a numbers standpoint, the clear majority are not only over 65, many are over 80 and 85. So this is the definition of palliative care that is increasingly being utilized. This is based on public opinion data. So this is not the definition that comes from us, the profession. This is the definition that comes from a random sample of 900 likely voters that was done a couple of years ago. What we did with this public opinion survey research done by a very prominent Republican polling firm in Washington was give people kind of a list of characteristics of palliative care. And on that list was end-of-life care, hospice care, terminal care, the things that we doctors and nurses tend to use to describe what we do. And you'll note this definition was based on what the public ranked as the most important and valued components of palliative care. And you will note that nowhere in this definition does it mention prognosis, 6 months, hospice, death, dying, terminal, having to give up one thing to get another thing. That's policymakers and doctors and nurses talking. That's not patients and families talking. So the word serious illness was markedly preferred over advanced illness. Advanced illness means terminal in the eyes of the public. We doctors and other people tend to think it is a safer term. They're on to us with that term. Eligibility based on need, focused on improving quality of life as defined by patients and families. And by the way, the highest ranked component of palliative care was patients and families. I thought that was really interesting, was that the recognition of that we're all in this together and that there's not one patient, there's the whole unit, was their top ranked characteristic. Provided by a team, that was a very highly ranked characteristic. I thought it would be a negative. I mean, think about the number of people that pass through a patient's hospital room in a 24-hour period. It's something like 67, the number of different individuals, counting everyone. So I thought it would be a negative, but actually it seemed to imply to the public that we talk to each other. And it's true, actually, we do. That works with patients, families, and other health professionals to provide an added layer of support. So it's not the consolation prize for when we take you away from your regular doctor and throw you over the wall to hospice, to a completely strange team at the most vulnerable moment in your life. Who designed that? That we build in forcing people to separate from their trusted long-term doctor when they most need that person, and when they most need that sustaining relationship. So this is with your regular doctors, alongside your regular doctors, to provide an added layer of support. Any age, any diagnosis, any stage, at the same time as curative and life-prolonging treatments like David's patient, right? This is what people want. And as David pointed out, we have a healthcare system that's sort of designed over here by some policymakers' idea of what people want. But what people want is over here. And we really need to remember that they are the customer. We are not the customer. And start listening. And this is the conceptual shift for palliative care, where rather than give it at the brink of death, when somebody has a predictable prognosis and is willing to have their life-prolonging treatment taken away, it is delivered ideally from the point of diagnosis of a serious illness, with the ratio and nature varying across the course of the illness. So the domains of palliative care, the most important one is this communication skill, this listening. And this is a statement I heard at a meeting, and there was a woman in the meeting who has a 10-year-old developmentally disabled child. And she made a care map that put her and her child at the center of the map, and then showed in all these circles the literally 150 different entities she had to deal with for his care. That each one of us, as one of those entities, has no idea about the other 179. Her full-time job is dealing with the people at the school. It was just breathtaking to see her perspective on the healthcare system, in quotes, that she was accessing for her 10-year-old, who is not dying and will live for a very, very long time, but completely dependent. Physical, emotional, and spiritual distress, patient and family professional communication, and this is what we talked about at Grand Rounds this morning, this essential skill of understanding what matters most, what's most important to our patients and families, and then going from there to design a care plan around what matters most. And then not abandoning the patient when they leave the hospital. And this is what's distinct from, for example, the most rapidly growing specialty, hospital medicine, hospitalists. Until very recently, once that patient was discharged, not our problem. Similarly, if you're the private practicing oncologist or cardiologist and there's a call after 7, your tape says call 911, not your problem, right? Palliative care teams, it's our problem if that care plan, that discharge is not sustainable. So for example, we will often fight the discharge planners who want to get somebody home today, say no, not today, not till the hospital bed is delivered, not till the opioid prescription is filled and on the kitchen table, otherwise he will be back tomorrow afternoon. And so it's understanding that that safe discharge is not optional, it's a necessity if you don't want that person coming back. So as David said, the future of palliative care, it's clearly not enough to have access in hospitals. Most illness, the overwhelming majority, occurs in the community. We need home palliative care without regard to prognosis or goals of care. And so this is the goal: the hospital consult service, the inpatient unit, the outpatient clinic, the cancer center, the outpatient palliative care and primary care practices, nursing home services, and most important of all, provider home visits. And your system, Christiane, I had dinner with some of your wonderful leaders last night, is well on its way to building this continuum so that patients, as they inevitably move through what is often a multi-year course of illness, are going to receive high-quality palliative care wherever they happen to be in the system. So the short for that is palliative care for everyone, everywhere. That's my personal mission. So David talked about, well, everybody here has talked about value. And I'm sure because you have the Value Institute here, you are inculcated in what value is. But many clinicians have never heard the term. Value is quality in the numerator and cost in the denominator. So what's the classic example of a high-value medical intervention? Enormously helps, costs very, very little. Vaccination is the classic example, right? Fractions of a penny per dose saves millions of lives per year. That's a really high-value medical intervention. What's a low-value medical intervention? Something that doesn't do much good and costs a huge amount. Resuscitation. Provenge is my latest favorite, $9,000 per dose, median gain in life expectancy 17 days. Taxpayer dollars. Did you guys know that the FDA by law is prohibited from considering cost in drug approvals? Okay. Anyway, we won't get any further into that. So these are a couple columns on data on outcomes of palliative care in different studies. Quality on the left, costs on the right. So palliative care is the sort of perfect storm, right? Improves quality and reduces cost. Okay. How does palliative care reduce cost? by improving quality. Okay. So it's really important to understand, and this is something Don Berwick says, that the cost reduction is an epiphenomenon of improving quality. Okay. Mr. B, 4 hospitalizations, 4 ambulances, 4 ED visits for something that could have much more effectively and with much higher quality been attended to at home, even if there was just an 800 number or a 24/7 number to call. Much better quality. Consequence of better quality, doesn't have to call 911. So it's really important that that distinction is crystal clear in people's minds. The minute people start talking about palliative care as cost savings, as a means to cost savings, we are a death panel. We are not a means to cost savings. We are a means to better quality, and oh, by the way, better quality helps people avoid the ED and the hospital, and we have to get our language very disciplined about that. So this is just, I'm going to show you some studies of high-value interventions that have been proven to improve quality and reduce costs. This is the randomized controlled trial of outpatient palliative care in advanced lung cancer patients done at Harvard that showed that not only was quality of life improved, depression reduced, utilization at the end of life reduced, but shock and surprise, these patients actually lived 2.7 months longer. Let's say, for the sake of discussion, that this study is replicated in places that aren't Harvard and the Mass General Lung Cancer Program in the real world, that it might apply to other patient populations beyond cancer and other types of cancer. For the sake of discussion, let's, for the moment, accept that this is a real survival advantage. If this was a chemotherapy agent, I'd be rich. Everyone would be on it. Okay. So what do you think the mechanism of action might be for a life prolongation in association with palliative care? Why would care coordination and support prolong life? I'm trying to get you down to mechanisms. If you're a scientist, you want to say, yeah, that's nice, that's touchy-feely, that's Hallmark card, but how? Actually, how? Does it... Less iatrogenesis, right? If you are, in this case, a lung cancer patient, David's patient, you are immunosuppressed, you are receiving chemo, radiation, your immune function stinks, and you come to the hospital and you get C. diff, you die. Okay. Hospitals are really dangerous because of infection risk, because of medical errors. It's no one's intention to cause harm. But if you don't have to be there, you're much better off somewhere else. So reduced iatrogenesis is one. So ability to complete appropriate medical treatments. If you're not in pain and you're not depressed, you're going to show up for your chemo infusion. You're going to get there for your radiation. So the symptom burden actually makes it very difficult for people to complete a course of treatment. What else? Yeah, so certainly identifying things that, if allowed to simmer along, could kill you, but if they were identified early, like an infection, could actually prolong your life. What else? It's up there. So why would improved quality of life help you live longer? So interesting. I mean, this is so obvious to most people, but if you ask doctors this question, like, what importance is quality of life and happiness to survival? That's like not, we don't believe in that. It's meds, it's, you know. So stress on the whole system. So you see that major depression reduction? It was actually a 75% reduction in major depression. We know from data in virtually every diagnosis in which it's been looked at, dementia, stroke, heart disease, cancer, that depression is an independent predictor of mortality. If you have cancer and are also depressed, you will die sooner than a matched control who doesn't have depression. What the mechanism of action is of depression's contribution to earlier death, not clear. There's increasing bodies of data on the sort of neuroimmunology, whether it's cytokine load. Nobody really knows what the biological mechanism is. I presented these data at a grand rounds in Cincinnati a couple years ago, and for the first time in my life, there was some basic scientists in the audience. That never happens in palliative care talks. Just like they're just in a different planet. So this time there were some basic scientists in the audience, and we were talking about this study, and one of the PhDs in the back stood up and told me about a study that had been published in Cell a couple of years ago. And this was a randomized controlled trial of immunosuppressed mice. So they'd been transplanted, they were immunosuppressed. They were randomly assigned to sort of best animal practice, you know, clean cages, the right food, infection control, but they were alone. They didn't have a lot of toys. They didn't have chamois cloths to burrow under. There was no particular attention from the staff in the lab. There were no other mice. The intervention group had a much more interesting environment. They got talked to by the staff. There was soothing music. They had things to burrow into and play with. They had toys, and they had other mice. So guess which group lived longer? 4 times longer. So it was the intervention group, in case anyone's wondering. But the guy said to me, so in my lab, we were talking about this study, and we looked at each other and said, we're wasting our lives. It's interesting that the basic scientists could see that, you know, another drug, a different carbon moiety on a drug wasn't the issue here. It was social. It was social supports. It was quality of life. It was having fun. It was, you know, in mice. They are mammals. They're not that far distant from us. But our whole healthcare system is the control group for those mice. This is the Kaplan-Meier statistic on the survival, really marked improvement in survival in the early palliative care group. This is a RCT from Kaiser, which, as everybody knows, has a single budget, right, for the year. So everything's at risk. There's a budget. And Kaiser can see how much money they're spending in each separate setting. So they did a randomized controlled trial of a home palliative care initiative very similar to David's. The control group got the regular certified home health agency without the hospice nurse, without the added layers of support. And you can see if you just looked at the left, there were 3 times as many palliative home visits as usual care home visits. And if you were running a CHOP, you'd say, well, that's really nice, but who's going to pay for that? Medicare's not paying me for that. We can't do that. But it was Kaiser, so they could see the downstream impact of providing much more intensive home care for people who were not, these were heart failure, COPD, and cancer patients. They were not hospice eligible. Marked reduction in utilization in every other setting. Their return on investment was about 4 to 1. So Kaiser, while we think of it as one system, it's hugely variable across the country. But in general, Kaiser is trying to roll out this home-based palliative care, as the VA has done, across their system. Now, why are Kaiser and the VA doing that? Because their incentive is to bring value. That's, you know, they don't have the choice of charging fee for service, and the more they do to people, the more money comes in. That's not an option in that system. So they're way ahead of the rest of the system in recognizing that if you meet people's needs at home, they don't come to the hospital. There's some data now developing on palliative care in nursing homes. This is from Hebrew Rehab, also at Harvard, showing that dementia patients who were hospitalized, who got a subsequent nursing home-based palliative care consult, were significantly less likely to go back to the ED. This is another RCT. I really like this one because it points to what David pointed out, which is the importance of the phone and access on the phone. It's very inexpensive. It's very cheap. This was an RCT of RNs, not advanced practice nurses, RNs doing a telephone checklist intervention with cancer patients who lived in rural Vermont and New Hampshire, too far of a distance from the Dartmouth Cancer Center to drive in. So they were randomized to usual care versus a nurse with a checklist who called preemptively, didn't wait for the emergency, called at some preset frequency using a protocol. And asked things like, how was your pain today? What was your worst pain? What was your best pain? How much meds are you taking? When was your last bowel movement? Are you sleeping okay? And then asks Mrs. Jones, the wife, how are you doing? Have you had a break? When are you going to run out of pain meds? The obvious stuff that leads people to the ED. And this was a pretty small study, only 322, again finding with just a telephone intervention, better quality of life, less depression, lower symptom intensity, and with a P of 0.14, an interesting trend towards better survival in the intervention group. Marie she just moved to the University of Alabama. She's just analyzing data on a larger R01 of the same model. And I am waiting with bated breath to see her survival data. Because if this improves quality and reduces cost, this should be universally available. And it's exactly what David said earlier. What do we know about the failure to refer to appropriate support services earlier? This is very important data from the Coping with Cancer study, again from Harvard, from Dana-Farber, that looked at the family consequences, the survivor consequences of business as usual in our hospitals and ICUs, and found that family members of patients who died in an ICU had a 5-fold increased risk of post-traumatic stress disorder as compared to family members of people who died at home on hospice. These are huge social costs that we don't count. We count the patient costs on claims data. We don't count the ripple effect of the harm to families and family systems from this. And also those who died in hospital, their loved ones had a nearly 9-fold increased risk of prolonged grief disorder. So arguably, this in some ways is the largest cost of business as usual in our hospitals and health systems. And the New Yorker, I could have just showed you this and sent you home. Good luck with the American healthcare system and the drugstore. These are a couple studies on the cost side of the value equation. This was an 8-hospital study done by Sean Morrison that showed an adjusted net savings of $4,908 in direct costs per admission for people who died in hospital compared to people with palliative care who died in hospital versus without. And the cost savings was something like $2,700 per patient who got palliative care and was discharged alive. And interestingly, this finding, this cost differential of hospital palliative care has been replicated with high fidelity in terms of the amount saved in multiple other studies, which is surprising to me. But we did a very similar study looking only at Medicaid beneficiaries in 4 high Medicaid penetration hospitals in New York State and found even larger cost savings against the myth that the poor don't want palliative care, that the poor will reject palliative care. That is not the experience in these 4 hospitals. It is a matter of trust and relationship. And if the quality of care is good and people trust and they're listened to, they're just as likely as any other group in society to accept care that is focused on what is best for their loved one. This is a geriatric model that I think we should all be looking at. It's called GRACE. It was developed by Steve Council, also in Indianapolis. And this is focused on duals, so people with both Medicare and Medicaid, a very high cost, high risk, vulnerable population. Their model, similar to the one that David described, only this one uses an advanced practice nurse. And they've, again, found improved quality of life in the patients and families and a $1,500 per member per year savings. This is hospital at home data that David referred to that was developed by Bruce Leff, a colleague of yours from Johns Hopkins. And this actually has had multiple randomized controlled trials, had a Cochrane analysis, found not only that patient satisfaction was better, as David pointed out, but a nearly 40% reduction in 6-month mortality. Again, if this was a chemotherapy agent, we'd be rich. It would be everywhere. But it's a system of care innovation, so it's nowhere. They also found total spend net of program cost reduced by almost 20%, and then this was mediated by reduced length of stay and reduced imaging and lab testing. So this wasn't everyone who came to the ED who's eligible for hospital at home. You know, there had to be family support, had to be someone who didn't look like they were going to need the ICU. There are criteria for hospital at home. But a very large number of people that we admit, because we have no alternative, would be much better off in terms of survival, getting their care at home. So payers have figured this out. If you're a payer, you want to do anything you can to keep people out of the most expensive setting. If your only concern is your shareholders' return on investment and not quality of care, just looking at it from a straight business standpoint, you want to figure out how to keep patients like the one David presented, like the one I presented, out of the ED, out of the hospital. And if you look around the country, it's commercial payers, both those supporting Medicare Advantage programs, those investing in Medicaid long-term care programs, those working with accountable care organizations that are very hot on home-based palliative care because they see which side of the bread their butter is on. That if you manage the sickest 5% at home effectively, many of them will not need to go to the hospital. And we've talked to you about a couple cases. And here's just one example. You guys have heard of DaVita. It's a huge multi-state for-profit dialysis company that's making lots and lots of money on taxpayer dollars. They just bought something called Healthcare Partners, which is a house calls program, very similar to the wonderful house calls program you have here. And they are making a 15% positive margin on a full risk per member per month contract. Okay. That's a big profit in healthcare. In some ways, more important than the dollar outcome is the job satisfaction of the doctors working in the system. And I just pulled out this quote from this guy, Dr. Doerr, who was a hospitalist before he started doing this work. Now, instead of 30 to 40 patients per day, Dr. Doerr sees 6 to 8. And he talks about how he looks forward to work now, and he used to hate it because he feels like he's really helping people. So here's just one example of a model very similar to the one David described that I think is the future that's here now, but just not very evenly distributed. And this one is from southeastern Michigan. It was developed by folks at the Hospice of Michigan. Dottie Daramo is the leader there. And she did this in partner with Blue Cross Blue Shield of Michigan, which is by far the largest payer in Michigan and accounts for about 75% of the state of Michigan. So having a dominant payer is an advantage if you're trying to work out system-wide models of care. And so they work with Blue Cross Blue Shield of Michigan, also with 3 different ACOs, 2 of which are pioneer ACOs in southeastern Michigan, and some big employers. And in their pilot data, they found improved quality outcomes, symptoms, quality of life, satisfaction, better family outcomes, and a 30% net total spend savings, net of program costs. Now, I think it's important to note that their targeting of patients is very disciplined. So they do not take care of people with serious and persistent mental illness. They do not take care of substance abusers. They do not take care of homeless people. Their perception is their model will not help those people, that the needs of that patient population is completely different than what a medical model can provide. So they sort of engineer their success in a way by making sure that they are matching their intervention to a population that can actually benefit, and there's a take-home message in that. So they get this feed from Blue Cross Blue Shield of Michigan of people with high utilization and high-risk diagnoses, but they don't stop there. They then put them through an analytic process, and they find out about functional impairment. They find out about cognitive impairment. They find out about family burden. You don't get that from claims data. And then they determine eligibility. They have the most important thing that they do, and the thing that gets the most utilization is the 24/7 access to a phone number, so that instead of calling 911, they can reach an RN who has access to their electronic medical record and can talk them through what to do. They also put transition coaches in the ED and the hospital because there's so many screw-ups between the institution and the next setting. And they have, as a small component of what they do, the ability to send someone to the home to give IV fluids, the ability to send someone to the home to give a shot of an antibiotic. They can do that 24/7. They don't do it much because they find that most of that need is obviated by being able to reach someone on the phone. So here's a whole bunch of models that have been proven to improve value. The point I make on this slide is that we do know what to do, we're just not doing it. Okay. There is a ton of data on models that have been proven to improve quality and reduce costs, but we act like they're not there, and we don't seem to know how to execute on them as a system. So I just want to talk about the key characteristics, because you've got a very insightful, visionary system here that is really focused on value as a system and as a community. I wish every system I visited had this kind of leadership. So you're ahead of the pack in terms of recognizing what needs to happen and what's important. And I just want to point to what I've pulled from the literature as the key characteristics of effective models. So payers understand this, that the highest risk, highest cost patients require high cost interventions to keep them out of the ED in the hospital. The provider side doesn't seem to understand that in the same way. It costs more. You got to invest the resources adequate to the problem if you want people not to have to call 911. So, and fortunately, as David pointed out, now that more and more systems are accepting risk, whether it's Medicare Advantage or becoming an ACO or 30-day readmission penalties or hospital mortality penalties, systems are realizing they have to invest in order to save. This is just an example of a targeting mechanism. This is a frailty index, mild, moderate, and severe frailty, and the Kaplan-Meier survival statistic. People with mild and moderate frailty, 80% are alive at 1 year. People with severe frailty, 50% are dead at 1 year. So one of the characteristics you would look for is frailty as a way of predicting who needs this high-cost intervention, who doesn't. This is a really important study done by a Catalonian Spanish colleague of ours named Xavier Gomez Batiste, who published in BMJ Supportive and Palliative Care, and he did a survey of all the primary care docs in Catalonia. In northern Spain, everyone has a primary care doc. Every primary care doc knows who's on their panel and has an electronic medical record, and the question to these primary care docs was the surprise question. On your panel, who would you not be surprised if they died in the next year? And by the way, the surprise question developed some years ago by Joanne Lynn turns out to be quite an accurate predictor of prognosis. It's better than asking a doctor, when is this person going to die? Because we don't know. And there's a lot of uncertainty. But you could ask me, would you be surprised if this person died in the next year? If I say no, I wouldn't be surprised. These are the patients in these Catalonian doctors' practices where they wouldn't be surprised, and look where the highest proportion is. Dementia and advanced frailty, over half. Not cancer, not heart disease. I mean, they're in there. But the characteristics that these doctors relied upon to figure out who was at highest risk was not a list of ICD-9 diagnoses. So, I'm pointing to the importance of targeting, but I don't want to suggest that it's easy. It's not as easy as utilization statistics and lists of ICD-9 diagnoses. And why is it important to target? You know, many of those huge Medicare care coordination demos that failed to show an impact, they did not target. They were providing a very expensive intervention to a population who didn't need it, as opposed to a very high-risk population. So it's critically important not to say, oh, come one, come all. You will lose your shirt, and you will not be able to show an advantage of the model. So the patient identification and risk stratification are key. We've already talked about the medical characteristics, but the social characteristics are equally key. So if this is a homeless person or a substance abuser or an alcoholic, I can tell you right now that they will be a high utilizer. And if you don't put a social support intervention in place, nothing else that you do will reduce their utilization or improve their quality. Just for your information, the California Healthcare Foundation has a great targeting toolkit for free on its website. They did a really nice job of pulling together all the data on targeting, and I commend it to you. So I think it would be really nice to put in the EPIC electronic health record a series of questions like this that primary care clinicians, nurses, nurse practitioners, doctors answer. Would you be surprised if this patient died in the next 12 to 24 months? Does this patient have decreased function? Have they been losing weight without trying to? Have they had 2 or more unplanned admissions in the last 12 months? Are they a nursing home or assisted living resident? Do they need more help at home? And do they have, or do they have 1 or more advanced long-term conditions? So targeting, I spent a lot of time on it because I think it is so important to these models. The second key characteristic of successful models is goal setting. And using the word goals with patients and families is a non-starter. Goals doesn't mean anything to patients and families. It's like, what? So the right question is, what is most important to you? What matters most to you? You'll hear things like, I want to make it to my daughter's wedding. You almost never hear, I want to live forever. I have never heard that response to that question. This is a quote from some geriatrician colleagues of mine. And it's interesting to see how the field of geriatrics and the field of palliative medicine are aligning around what have always been the core principles of palliative medicine. So this is Dave Rubin and Mary Tinetti saying in the New England Journal last year, ultimately good medicine is about doing right for the patient, for patients with multiple conditions, disability, limited life expectancy. Any accounting of how well we're succeeding must, above all, consider patients' preferred outcomes. I mean, duh. So this is a great study that Terry Freed did up in New Haven a couple years ago, where she surveyed 357 senior center people and asked them to rank order what was most important to them. That was how the question was phrased, not what are your goals, but what's most important to you. And the choices were staying independent, being free of distressing symptoms, or living longer. And of course, remaining independent was ranked first, and not being subject to overwhelming symptoms was ranked second, and living longer was dead last. How is the healthcare system designed? So, there's a little bit of data. Some is contradictory, some is supportive, but this study found that among Medicare beneficiaries in high Medicare spending regions of the country, the presence of an advance directive was associated with lower Medicare spending, lower hospital death rate, and higher hospice use. And again, from the Coping with Cancer study, just really important data that families who could recall a conversation about prognosis and goals of care was strongly associated with their estimate that their loved one got better care, lower costs, lower adverse psychological consequences for families. So the very thing we think they don't want to talk about, the very thing we are terrified of approaching them with, we feel like we're beating them about the head with a baseball bat, is the thing they need most. They know what's happening. Anyone can see it. Families know. When we don't talk about it, they're going to feel awkward bringing it up, because they might think it seems as if they're advocating for their loved one's death. It's our job to bring it up. It's our job. It will not come as a surprise, I promise you, to the patients and families who are living with a serious life-threatening illness that they have a serious life-threatening illness. It will not be news to them. The third characteristic is this recognition. Remember, you mentioned, why is dementia such a high utilizer? It's because the family caregivers can't take it another minute. Okay. And these are data on the number of unpaid hours of care given by non-professional family caregivers worth about $500 billion per year in current dollars. They are doing wound care. They are administering medications. They are doing things that we require RNs to do in our certified home health agencies. And they have an increased risk of disease, death, and personal bankruptcy. So a huge public health cost of what we burden families with. And I think this is among the most powerful pieces of evidence about the mismatch of how we spend money in our healthcare system. This is a study from Betsy Bradley that was published in BMJ Quality and Safety in 2011, and it shows the ratio of social spending to medical spending in nations across the globe. And you can see in Denmark and the UK, the ratio of social to medical spending is about 2.5 to 1. The United States is the lowest. Okay, our ratio of social spending to medical spending is 0.8. So there's a relationship between these things. We also spend twice as much as our nearest developed nation neighbors on healthcare per capita because we provide no social support. So Mr. B has to go to the ED. David's patient has to go to the ED. It's really obvious and simple to me. So I love this. This was an analysis of 25 different states that are doing the shift of their long-term care budgets away from nursing homes and to home and community-based services. We know that patients want to stay home, right? There's lots of data on that. So there's been what's called an institutional bias in Medicaid, which is we're willing to pay for you to be in a nursing home, but we're not willing to pay for support at home. But 25 states are trying to shift that bias. And their estimate is the costs of taking care of long-term care patients at home is about 1/3 that of taking care of them in a nursing home. And oh, by the way, that's where they'd rather be. This is really great. This was last week in Health Affairs. That found that if all 48 contiguous states increased by 1% the number of older people who got meals delivered to their homes, it would prevent 1,722 people on Medicaid from needing nursing home care. Social supports. Really simple. And here's a study just on the homeless, and this is, I'm sure, obvious to all of you, that provision of public housing to the homeless leads to marked decrease in health services utilization. So families and communities need help. We've got to mobilize. It's our job to mobilize the community supports, and if they're not there, to make sure they get developed. And the predictors of success of these models is that 24/7 phone access, having the care relationship be with someone from the community, not the different nurse every week from India, but someone who you know by first name, who is a consistent person, who comes to your house, that you trust. That is critical. And that it not be a different person for your heart failure, yet a different person for your cancer, a third person from the home health agency, a fourth person from, the transitional care team. We've got to get it down to one person who is empowered to deal with all aspects of that. And that person has to be trained to mobilize social supports as well as medical supports. So that's the third key characteristic. The fourth key characteristic is what I told you before, that 90% of ED visits in people over the age of 65 are due to symptoms. And that if we don't have teams that know how to manage symptoms, as David's patient, as my patient, they will end up in the ED, very predictably. I love this study from Alex Smith that found that pain of moderate or greater severity that is often troubling is reported by about half of people over age 65 in their last 4 months of life, and the overwhelming majority of the causes of the pain was arthritis, not cancer. We trivialize arthritis pain. It is disabling. It keeps people from functioning. It sends them to the ED. And it's not only pain. This is a study from Lisa Walk, published a few years ago, looking at the symptom burden of community-dwelling older adults. Pain is one, but there are many others. So obviously, the people caring for people at home need to be trained in palliative care assessment and symptom management. And the fifth characteristic is interesting when you think about David's model, and that is that there's a dynamic nature of risk. You see the sine wave. Much of the time, people don't need anything other than that 24/7 phone number and a check-in call every 2 weeks or a month. And that's a very inexpensive model, but it needs to be able to ratchet up immediately if someone gets a fever or has a pain crisis. So we need to be able to dose adjust our community care coordination models, and neither certified home health agencies nor hospice are able to do that under statute. It's one size fits all if you're eligible. And that's insane because disease occurs longitudinally and needs vary. And we're wasting money because of the rigidity of our models. So here's Gomez Batiste again, who I think actually is among the most insightful thinkers about the public health nature of the challenge that David and I have talked to you about. And he's argued that we need to stop talking about terminal disease and talk about advanced chronic or serious illness. We shouldn't be talking about short prognosis. We should be looking months to years. We should shift our focus beyond cancer to all chronic progressive diseases. We shouldn't be talking about diseases. We should be talking about frailty, multiple conditions, functional impairment. We shouldn't be talking about mortality, but prevalence. You know, when we get fixed on who's going to die when, we're missing the vast majority of patients that need us that end up coming to the ED. Not cure versus care, but both life-prolonging treatment and palliative treatment. Not disease or palliation, but disease treatment and palliative treatment. Away from prognosis as criterion over to need as criterion. From a reactive model that waits till David's patient and my patient show up in the ED 4 times in 6 months to finally figure out that maybe we should be doing something differently, to a screening and proactive planned model. From a specialist model, there will never be enough geriatricians and palliative care doctors, nurses, and social workers in 10 lifetimes to meet the needs of all the patients we're describing. We need to get to palliative and geriatric care everywhere. Every clinician needs fundamental skills and competencies. From institutionalized care, nursing home, hospital, to community care. From completely absent regional planning to a public health approach, which your Value Institute gives you a huge step up because that's how you're thinking. And from fragmented care to integrated care. And I actually often close my talks with David's last slide, which I love and stole, about the future is here now, just not very evenly distributed, but because I knew he was going to use it. I got rid of it and came back to another old favorite. Helen Keller wrote this wonderful essay called Optimism, which you can find online, in which she said the world is full of suffering, but it is full also of the overcoming of it. And many of you here are at the vanguard of those efforts. So it's been a real privilege and an honor to be with you. Thank you.